Hello, I am Dr. Elmar Sakala, and this is Kaplan Obstetrics and Gynecology. I am from Loma Linda University Medical Center in Loma Linda, California, 60 miles east of Los Angeles. And my particular area of interest and specialty is maternal fetal medicine. But we're going to talk right now about gynecology. We're going to start out with basic principles of gynecology. That will be initially the female reproductive anatomy. Now, you know a lot of this already. We'll just review it for the clinical topics that we will talk about later on. We start out with the uterus. Embryologically, it has its origin from fusion of the two Mullerian ducts, as you will remember. We'll talk about that in some detail later. Various anomalies because of failure of fusion of the Mullerian ducts. The major structures of the uterus are the corpus of the uterus. Corpus means body, which is the main part. The cornual area of the uterus is where the oviduct, the fallopian tube, has its origin in the wall of the uterus. The isthmus, which joins the uterus and the cervix together, and the cervix, which is the lower part and has the exit into the vagina. The corpus is made up mostly of smooth muscle. The cervix is mostly of collagen. And when we talk about labor, you'll see how important that is. The internal layers of the uterus are the serosa, which is the outer layer, which provides a smooth, lubricated surface where the structures in the abdomen, the bowel, and the viscera can slide easily over each other. The myometrium is a smooth muscle, which is the main part of the wall that contracts with labor, and the endometrium, which has to be very well blood supply in order for implantation of the early embryo. The attachments of the uterus are to the broad ligament, to the round ligament, to the cardinal ligament, uterosacral ligament, and when we have failure of support, then we have uterine prolapse. We'll talk about that later on. The positions of the uterus can be anteverted, which is the most common, retroverted, which still can be normal, but if it is fixed and retroverted, you need to think of adhesions from either endometriosis or chronic PID. This image shows you the two internal genital ducts which are present in any embryo. We have the Mullerian duct and we have the Wolffian duct, and this is in every embryo. In the female, the Mullerian duct will develop, and this is the default differentiation. In order for the Wolffian duct to develop, we need to have androgens, and we'll talk about this more later on. We have then the fusion of the Mullerian ducts. Here are the ovaries, and on this side are the testes in the male. So here we have the uterus. This is the corpus of the uterus, the part of the uterus. Here you can see the cornual area where the tube, fallopian tube, and the uterine cavity are joined. Then we have the cervix, which is mostly collagen, and this is the isthmus, which is the joining of the corpus and the cervix together. Okay, this image is a sagittal view of the pelvis, and you can see here is the uterus, this is the vagina, here's the bladder, here's the rectum. What I want you to notice is the thin endometrial stripe, which is the anterior and the posterior walls of the uterus, which are against each other. It shows up very nicely on ultrasound and on MRI. Notice the angle between the uterus and the vagina. It's a 90-degree angle. You can see it even better with this picture here. When we get uterine prolapse, that angle is lost and the uterus goes in the same orientation as the vagina. Here we see the various versions of the uterus. We can have an anteverted uterus, which is the most common, a mid-position, and a retroverted uterus. It used to be thought that a uterus that was retroverted was associated with infertility. It is actually not. It is if the uterus is fixed, if it is adherent to the cul-de-sac because of either adhesions from endometriosis or chronic PID, that you can have infertility. Procedures were done to lift the uterus up. They call this a uterine suspension, no longer done. This shows one of the main supports of the uterus, which is the broad ligament, and that comes from both sides of the uterus from the pelvic side wall. This picture shows very nicely the three organ systems in the pelvis, which we'll talk about at some length. We have the uterus, which is a reproductive tract. We have the bladder, which is the urinary tract. And we have the colon, which is the GI. And so when we have pelvic mass, when we have pelvic pain, we need to think of these three organ systems. Now we move to the oviducts. The oviducts extend from the uterus to the ovaries. There are four segments of the oviduct: the interstitium, which is from the uterine cavity through the cornal area of the uterus, the isthmus, which is the proximal tube, the ampulla, which is the mid to distal, and the very distal area is the infundibulum. The functions of the oviduct are twofold, and they are to facilitate in one direction sperm migration from the uterus to the ampulla of the tube, which is where fertilization takes place, and then when the zygote has been fertilized, it transports it from the tube toward the uterine cavity. And both of these are very important in order for reproduction to occur. The oviducts are attached medially to the uterine corpus, laterally to the pelvic sidewall, and inferiorly to the broad ligament. I'll show you a picture in just a moment. The blood supply to the oviduct is dual. It comes from the ascending branch of the uterine artery and from the ovarian artery. And this is an important point because pelvic organs have a lot of collateral circulation. And if we have postpartum hemorrhage from uterine atony, we could actually tie off the uterine arteries, and you will not get ischemia of the uterus because you get the collateral circulation from other sources. This is the fallopian tube. You can see here is the interstitium. Here we have the proximal part of the tube, the infundibulum, which is over here. This is the ovary, and you can see how the tube picks up from the ovary the egg which has been extruded at the time of ovulation. This picture shows very nicely the dual blood supply. On the one hand, we have the uterine artery, which comes up here and supplies the tube. And then we have from the ovarian artery, which comes from here. It also shows very nicely the entry of the ureters, which come into the bladder, and the bladder is attached anteriorly to the uterus. You'll notice the close proximity between the uterine artery here and the ureter. And when you are doing a hysterectomy, you better be pretty careful that you don't clamp off the ureter when you're taking out the uterus. And here is the vagina and the cervix. The ovaries, they contain the oocytes within the follicles. I'll show you a picture of that. The ovaries produce the reproductive and sexual hormones. We'll talk at some length on this when we look at menstrual disorders. The attachments of the ovaries: the ovarian ligament to the uterine fundus, which is medially, the suspensory ligament to the pelvic sidewall, which is laterally, and the mesovarium to the broad ligament. And the ovaries basically are hanging in midair, suspended from each of these three sites. The lymphatic drainage is to the pelvic and para-aortic nodes. Here you can see the ovary, and within the ovary are follicles in various forms of development. You can see here we have the primary follicles, which become the secondary follicles, which become the Graafian follicle, and here we have ovulation, which takes place. Then we have the regression of the corpus luteum, which will then form the corpus albicans. Here you can see the ovary with various levels or stages of development of the follicle. It is important to notice the ovarian stroma. The ovarian stroma produces androgens. And even a postmenopausal woman who has no follicles left, even though she's not producing estrogen from her ovaries, she does produce androgens, and those are important for libido. Here we have the Graafian follicle, which is the large follicle just prior to ovulation. And ovulation, you can see, breaks through the ovarian capsule, which is here. As we'll talk about later, ovarian cancer, which is the worst kind of gynecologic cancer, is often found in late stages, but it arises more frequently in women who have had many, many ovulations. And what it probably has to do with is repair of the ovarian capsule. And in that reparative process, we have the neoplastic changes. Okay, and finally we come to the vagina. The vagina is a tubular structure, average 8 to 9 centimeters long, extending from the vaginal introitus to the cervix. It traverses the urogenital diaphragm through the genital hiatus of the levator ani. This is going to be important when we look at vaginal prolapse, because when you have relaxation of the pelvic diaphragm, then you can have involvement of the vagina. It functions as the female copulatory organ with intercourse, outflow tract for menstrual flow, and is the birth canal in parturition or delivery. This is the entry to the vagina in the perineum, as you can see here. And the vagina is a muscular organ which extends from the perineum to the cervix. Okay, that's the end of female reproductive anatomy.